to share his overview of the latest advancement in the diagnosis and management of celiac disease. And I have to say, when I was in clinical practice in the NHS, this was one of my favourite areas, and you could really see and make a huge difference, I think, with your work. And I'm really looking forward to hearing how this whole area has advanced. As ever, and with that now, so the statement tonight, see how you're feeling. I'm very aware of who needs to get tested for celiac disease and what specific tests are needed to confirm that diagnosis. So how do you feel about that in terms of your latest knowledge and practice? So do you strongly disagree, it depends, agree, or strongly agree? So I'm just going to go to my trusty polling station to the right to see those votes coming in. And thank you so much for doing that, because it really helps the speaker, I think, gauge the content for you as you know, as he progresses. And also us for our evaluation to see, you know, whether we're truly helping you with these events. Thank you so much, Pip. We can close that now and just run some results, share them with everyone. Okay, so 13% strongly disagree, 26% disagree, 27% it depends, 28% agree, and 6% strongly agree. So we have some experts in the audience, and we have potentially people who are looking for, you know, a real update. So that's absolutely fantastic. Thank you so much for sharing that. So also, just before we kick off, is really just to say that, to remind you that we do have a very, very short survey. It's actually in the chat box tonight, and it will also be on one of the final slides with a QR code. So please do complete us. It just helps us to iterate for you in terms of what we're doing. And thank you so much to everybody who actually completed last week. I found that truly helpful. And you will get your certificate of attendance, your link to the slides, the resources, the CPD reflection form, and of course the recording will be shared with you afterwards. And you will also later on get the popular, very popular, we're finding, visual infographic with the key messages, which will be summarized for you from this session, and that will be shared on social media and in our resources blog within a couple of weeks after the event. And please do check your junk before contacting us. So on to tonight, let me finally introduce our guest expert. I'm absolutely thrilled and honoured to introduce the hugely talented Christian Costas-Battle. Christian is a gastroenterology dietitian specialising in celiac disease. He runs a dietetic-led celiac service in the NHS, and he also works in private practice. And in 2020, he was awarded with the GUTS UK and the Dr. Falk Dietitian Recognition Award for improving care in gastroenterology through the dietetic-led celiac service that he set up. And in 2021, he won a double CN award as Clinical Nutrition Professional of the Year and Social Media Personality of the Year for his work in celiac disease. And our team certainly had a lot of fun with him at those awards. He's a very lovely human being to work with, which of course makes all the difference in life. So Christian, a huge welcome to you. We are so looking forward to your talk. Over to you.
Thank you. Thanks a lot, Tanya. It's you know, it's a huge privilege to be here, and I can't thank you guys enough. I've loved every part of the process, from starting to talk about how we would do this, the fact that we're doing 2 webinars to go into detail with things. So really, really excited about this and to shed some really good light on celiac disease.
Brilliant. Thank you.
So hopefully you can all see my slides now.
Yes, ready to go.
Good. I'm just going to try and minimize this. Perfect. Good. So hopefully everyone's in the right webinar about celiac disease, getting your update on diagnosis and management. So for those of you who know me, I literally do not shut up about celiac disease. So I love coming on here and being able to share all this information, giving a really good update, which I do a lot of these things on social media too, but it's great to do it in a webinar and reach so many different health professionals. So today what we'll be doing, just going with my slides, there we go. So today what we'll be doing is getting an update on the latest diagnostic changes in celiac disease. And I'll be talking about some new interim guidance from the British Society of Gastroenterology, which suggests using a non-biopsy approach for celiac disease. I'll also talk about some of the digestive and non-digestive symptoms of celiac disease, and I will talk about how patients present too, and hopefully give you some really good guidance to consider when people should be getting tested for celiac disease. And also we'll go into an area which a lot of people have questions about, which is non-responsive celiac disease, when we suspect patients aren't responding or improving with that gluten-free diet. So I'll give you some practical tips on what we can do to continue to help these patients. So first off, it's important to start off with what celiac disease is. As I'm aware, a lot of you will already know, this is definitely not an allergy and it's not an intolerance. It's actually an autoimmune condition. And it's an autoimmune condition that affects different systems in the body, which is why we call it a multi-system autoimmune condition. So it doesn't just affect the digestive tract. And really, with particular to this autoimmune condition, is that we actually know the trigger. We know the trigger well, whereas for other autoimmune conditions, we're not that familiar with triggers. We don't know it with certainty, but in this one, it's gluten when it is eaten. And unfortunately, we don't have a cure because it's a complex medical condition. And essentially, all we can tell these patients is that actually they take gluten out of their diet, then for most symptoms are going to improve. Some people won't get better on the gluten-free diet, or it'll take more time. And this is where we need a bit of an individualized approach, which I'll talk about. But essentially, most people will improve. So there's a really good recent research paper which has a really good diagram about what essentially happens when somebody who has celiac disease eats gluten. So essentially, when gluten's eaten, it arrives into the stomach. There's partial degradation there. So gluten's essentially protein, gets broken down into different components, and one of them is gliadin. And gliadin is a sequence of amino acids, basically a peptide, which then arrives in the small intestine, passes into the lamina propria, and here is where the body releases some tissue transglutaminase to further break it down. And these kind of hydrolyzed or broken down versions of gliadin then gets sort of eaten up by these antigen presenting cells, which are cells that are in charge of presenting these components to our immune system and saying, hey, can you check this? Is there anything to be worried about with this? Do we need to do anything, or is it fine? Essentially, this is where it kind of goes pear-shaped for people with celiac disease, because these antigen presenting cells present these broken down gliadin gliadin peptides, and essentially our T cells, our immune system here, say, right, they shouldn't be here, and they cause a cascade of changes within the gut. So they release inflammatory cytokines here, which then release what we call intraepithelial lymphocytes, which in turn will cause epithelial stress and start to damage the gut. And then what we see is that there's more of a release of these T cells, which then causes a cascade of changes, which can damage the gut. It can almost separate these type barriers that we see between these epithelial cells, and it allows more gluten to get in, causing more of a problem. And then these T cells will also produce what we call B cells that also release antibodies, which try to break down this gluten even more. So the reason why I'm saying this might be a lot of detail for some people, but really the reason I'm saying is because there's two things really we're trying to look for in a diagnosis of celiac disease. We're looking for some morphological changes in the gut, and we're also looking for certain antibodies that get released in response to gluten. So really, you know, a lot of people would want to know, well, what causes this? What causes this abnormal way of dealing with gluten? So we know there's some strong genetic components, and we know people have a genetic predisposition to have celiac disease, but not everyone develops it. We know that first-degree relatives are more likely to have celiac disease. But we also know there's environmental factors that can trigger this condition, and we know that things like infant feeding practices where weaning people with gluten too early can potentially predispose them to develop celiac disease. We know things like viral infections can cause things like celiac disease. Some people can develop it after having these viral infections. Things like stress can also cause it. So essentially, things that make that contribute to changes within our gut can potentially trigger celiac disease. And interestingly enough, I've seen a few patients now who have had celiac disease after having COVID. So it's in line with this viral infection that can change things within our gut. So one of the things that people think really is that actually, well, celiac disease, you know, it's linked to eating gluten, then surely it's just a condition of the West where, you know, people eat more gluten. That is definitely not the case. We have a lot of data to suggest that there isn't really a lot of data does suggest there isn't an association between gluten consumption and prevalence of celiac disease. There can be some levels of association with some different research, but it's really quite complex. And what we can see here in this diagram from a relatively recent research paper from last year is that actually prevalence of celiac disease, the darker red it goes, is the higher that prevalence. You can see it's actually prevalent in most continents. There's some countries there that we don't have data for, but you can see actually in some different continents outside of Europe, the prevalence can actually be pretty high. And a lot of this data was based on biopsy data, where people have had a blood test and a biopsy, which is a bit harder to get, because prevalence in, say, for example, we just looked at blood tests would be higher, and we know that from data. But basically on biopsy-proven celiac disease, we know there's a global prevalence of around 0.77%, and breaking up by continents, we know that Europe prevalence can be potentially higher, but then we've got prevalence in North America, South America, Asia 0.69, which is higher than a lot of people expect to. Got some prevalence data for Africa, Australia, and New Zealand too. So really, you know, a lot of the data does suggest that worldwide prevalence points towards something like 1%, although in some continents it'll be a bit higher or lower. And what we also know from this data, and a lot more data we've got on prevalence rates, is that celiac disease is definitely on the rise. So, this paper actually showed that there's been a 10% increase in worldwide celiac disease prevalence from 2016 to 2020. So what are the symptoms of celiac disease then? So this is a really good diagram from what I think is a really good research paper from Limfers and colleagues. And basically their diagram shows that whilst, yes, you know, celiac disease comes from the digestive tract, that's where we get the damage. There's some symptoms that can be associated with the digestive tract. They're like diarrhea, which people might know about, things like acid reflux, dyspepsia, passing wind, abdominal pain. People might know about things like weight loss too, but really, you know, these are just some of the symptoms that present with people with celiac disease. We have more and more data each year to suggest that more and more people present with these symptoms outside of the digestive tract, and it's actually quite common to see things like headaches, things like peripheral neuropathy, where people can lose sensation of their fingers and toes. We can see things like depression pre and post diagnosis. We can see things like chronic fatigue. These antibodies also can affect the brain, and people can have problems concentrating. People can sometimes have problems with balance too. So it's really important to understand that it definitely doesn't just affect the gut. We see quite a few people with mouth ulcers, dental enamel defects too. We see raised liver enzymes. We also see that about a quarter of patients with celiac disease have iron deficiency anemia, and they might be deficient in other vitamins and minerals too. Quite a few people can develop osteopenia, osteoporosis, and in fact, some people may present by having an unexplained fracture, and then when we investigate that, they've got low bone mineral density, and that might have been caused by the celiac disease. And some people can present with what we call dermatitis herpetiformis, which is a skin manifestation of celiac disease. So you can get skin rashes that can blister. They tend to present in the elbows and the knees, but can present in different parts of the body. So as you can see, this is what we call a true clinical chameleon, because the symptoms are common to so many other different conditions, which makes the diagnosis challenging. So really, with celiac disease, a lot of people are familiar with what we call these classical symptoms, and we used to think years ago that, you know, this is the only way patients really present. But as I've mentioned, there's all these non-classical symptoms, even things like fertility issues that people can present with, which don't make you think that that could potentially be celiac disease, which makes the diagnosis quite hard. And we also need to be aware of these other conditions that are associated with celiac disease, because celiac disease is an autoimmune condition. You've got an increased chance of having other autoimmune conditions, or if you've got some of these other autoimmune conditions, you've got an increased chance of having celiac disease. So dermatitis herpetiformis is actually, so many times it gets mentioned as a symptom, but it's actually a medical condition. So it's another autoimmune condition triggered by gluten that causes these skin rashes. So we also know that things like diabetes type 1, for example, people can have a potentially 5 to 10% chance of developing celiac disease when they have it. We know that people with autoimmune thyroid disease have an increased chance of having celiac disease. There's other conditions like microscopic colitis, psoriasis, lupus, and a few others that we know about. So some of you might be thinking, so how classical are these classical symptoms, which we used to think were prevalent in every patient? Well, actually, it's not that common to see patients with all of these digestive symptoms, or only digestive symptoms. And actually, what this research paper suggested was that really a lot of patients don't actually present with these. We know it's about a third that will present with the classical symptoms, but actually the great majority will present with the non-classical symptoms. So things like constipation, where most people would think it's diarrhea, well, constipation can be actually quite common in celiac disease too. Things like anemia, osteoporosis, raised liver enzymes, some of these neurological issues I've talked about, dermatitis herpetiformis. And then we know about 20% of patients won't have symptoms. So for these, it's going to be really hard to screen for them, and we'll mainly pick these patients up when we're either looking for something else or potentially screening them because they've got an increased risk of having celiac disease if they've got another autoimmune condition, for example. So some facts about celiac disease to place all of this information. So celiac disease affects about 1% of the population, so 1 in 100, as I mentioned before. That's what we know in the UK and in most countries. Yet up to 75% of people remain undiagnosed in the UK. So 3 out of 4 people with celiac disease don't know they have it, and that's about 500,000 people in the UK. And we know that up to a quarter of people with celiac disease have previously been misdiagnosed with IBS. And this is why it's so important to test people in the right way and make sure that we are excluding celiac disease before we give somebody a diagnosis of IBS, but also with other conditions, because as you can see, the symptoms in celiac disease are common to many other conditions. And really, it takes about 13 years on average to get a diagnosis. That's a huge amount of time because these patients don't always get severe symptoms. All of them will present in different ways, and this makes it really difficult for clinicians, and it makes it difficult for the patient to think that they need to get tested for something. And also we know that it can affect people at any point in their life. So this disease does not just onset at birth, it does not just onset later on in life, it can be any point, but a lot of our data does suggest that most people get diagnosed between the age of 40 and 60. There's a higher prevalence recorded in females. It's 3 to 1 from females compared to males in most countries, most data we have. And the diagnosis can unfortunately only be certain if the patient is eating gluten consistently. I'll talk about how much and further down the line, but this is a big challenge because many people will have removed gluten before they get checked because they find some sort of problem or they think it's better for some other reason. So unfortunately, this still remains a big challenge. And we know that people who are first degree relatives of people with celiac disease have a 10% chance of developing celiac disease. So it's important that we consider this to encourage these people to get screened for celiac disease. So you might be thinking, where do we start with testing then? So we've got some good guidance from NICE, our national guidelines. So what they basically say is that a lot of these digestive and non-digestive symptoms I've mentioned, it's worth getting people tested for celiac disease. We definitely want to encourage first-degree relatives of people with celiac disease to get tested, and this is important to discuss when we diagnose people with celiac disease, talk to them about family testing. We want to definitely screen celiac disease for people who've got type 1 diabetes or autoimmune thyroid disease, specially diagnosed in the first year, and we want to encourage them to get tested for celiac disease. If we see somebody with an unexplained vitamin and mineral deficiencies like iron, B12 or folate, definitely we want to encourage them to get screened for celiac disease. Then there's also this research paper from 2019, which actually puts it in a bit of a scale of priority, which might help too. And definitely we see some of these classic malabsorptive symptoms. We definitely want to test for celiac disease. It will be recommended for patients where we see some of these persistent GI symptoms. Fatigue is a really common symptom, and sometimes I've seen patients present with just fatigue, for example. So it's really important to bear that in mind. Things like mouth ulcers, thinking about these symptoms outside of the gut, these other autoimmune conditions, irritable bowel syndrome type presentation, first degree relatives. And then here are things where we need to really be thinking outside of the box and consider it with things like reduced bone mineral density, some neurological symptoms, fertility issues or recurrent miscarriages too, some of these dental enamel defects. And this is where sometimes the dentist might refer these patients and they end up getting diagnosed with celiac disease. So it's good to put this all into context, and hopefully that will help you to understand who we should be encouraging to get tested. Right. Oh, there you go. Sorry, it didn't seem to be moving. Okay, so how is celiac disease diagnosed in adults? So prior to the pandemic, as a lot of you will be familiar with, the testing started off with what we call an immunoglobulin A tissue transglutaminase. So this is an antibody which I mentioned before when I was talking about what happens with when people eat gluten. So this tends to be raised in the gut and then it goes into the bloodstream. So it's a good first way of screening people. And historically, if that were positive, then a gastroenterologist would perform an endoscopy, and it would take, rather than one biopsy, it's more than one biopsy that's actually needed. It's usually suggested to be 4 or more. We take those biopsies and then they're looked in the microscope to see if there's features of gut damage. And with those two, we would be able to say, right, this is celiac disease. Now, what's happened is that since the pandemic, there's been a new protocol released by the British Society of Gastroenterology. And essentially, this protocol takes into account a lot of the research that has been happening before, where we actually know that the blood test and celiac disease, two of them together, are really highly predictive of celiac disease, to the point that with certain patients, you probably don't need to go in and do an endoscopy. So this TTG and EMA I'll talk about are pretty much 98, 99% sensitive and specific. We don't have 100%, in medicine, but we know that these tests are quite accurate. So what the protocol suggests is that for people who are under the age of 55 that don't have alarm symptoms, so things like problems swallowing, blood in stools, issues where we think there's something serious going on apart from celiac disease, if they have an initial antibody screen that is 10 times above the upper limit, so some hospitals might have an upper limit of 7 or 10, for example, but we take 10, then that would be an upper limit above 100. That would be a value above 100, and with the upper limit being 10. So if they have that high value with their TTG, then really we can take another sample and test their EMA, which is another antibody called endomysial antibody. And if that is positive, these two together, we can say, right, this person has celiac disease, and really that is enough. They don't need to go for a biopsy. But if the patient's above the age of 55, there's any alarm symptoms, or the TTG isn't raised 10 times above the upper limit, for example, then we need to proceed with a gastroscopy to be able to first, to obviously confirm that that's celiac disease. And also in some cases, we will want to do the gastroscopy to make sure there's no other medical conditions going on. And obviously, once diagnosed, they should be referred to a dietitian to start on the gluten-free diet, which is standard guidance for every patient with most guidelines. So what should this diagnostic process look like? Because it's not as straightforward as what these slides might suggest, and I'll kind of go into a bit more detail with that. So when we've got suspicion of celiac disease, we first need to identify, right, is that patient willing to do a gluten challenge or not? Or are they on a gluten-free diet and don't want to reintroduce? Because we will see this with some patients. So when this happens, this is a test that probably more a gastroenterologist or a specialist service might do. We can sometimes do what we call these tests for these genetic blood tests, which is an HLA DQ2 or DQ8. And we know that with people with celiac disease have at least one of these. So for example, if we do that test and comes back negative, and this person can be on a gluten-free diet, comes back negative, we know there's almost 100% chance that that person doesn't have celiac disease. So we can say, right, that's not celiac disease, it's something else. But if that is positive, unfortunately, what happens is that people with celiac disease will test positive for one or two of these, but also the general population, about 30% of the general population can test positive for these without having celiac disease. So it's not diagnostic in itself, it just tells us, right, there might be a higher chance this person has celiac disease, so we really need to encourage them to do the gluten challenge and come back here and try to introduce gluten into their diet. And that's the only way we're going to get an accurate test for these people. So really what we want to do is encourage that person to eat gluten for 6 weeks daily, and nice guidance for the UK suggests that it's gluten in at least 1 meal a day. A lot of guidance elsewhere will suggest that really we want to ramp that up and try to get them to eat more gluten, something like a couple of slices of bread or equivalent per day. And I would definitely encourage that if the patient's happy to tolerate that, because really we want them to have a good amount of gluten so we can make the test as accurate as possible. And what we want to do with the initial screen is test for this TTG, this IgA TTG, but we also want to test for a total IgA, because this IgA TTG essentially is bound to immunoglobulin A, and people with celiac disease have a higher chance of having IgA deficiency. So if they have that deficiency, this test wouldn't be, the IgA TTG wouldn't be accurate because it can give us a false negative. It might not raise if they have an IgA deficiency. So for these patients, we would need to consider something else, which I'll talk about shortly. But if that TTG is positive, then really we can't just say that person has celiac disease. We need to perform a couple of other things. So we've known in children, for example, that they can avoid a biopsy, which is similar to this interim approach I've talked about. They have an EMA, so they've been able to do that since 2012. So that's been going for a long time in children. But in adults, previously, what had to happen was that they'd have to have a biopsy, and basically, if the biopsy showed damage, villus atrophy, we knew, right, that is celiac disease. But as you can see, it's a blood test, and it's also that endoscopy and that sample. Really, you cannot diagnose somebody just with villus atrophy, and I will talk about that later. So one of the other things here that we need to consider is that if someone has a negative TTG, right, and their IgA is normal, then we can say celiac disease is unlikely, but it doesn't exclude celiac disease with certainty. We can have a proportion of patients that have what we call seronegative celiac disease, where that TTG won't raise. And this doesn't happen in a lot of people, but it can happen. So if we've got high suspicion, then we need to go ahead, perform the biopsy. And then for some of these patients, the way we know is if they improve in a gluten-free diet, we can say, right, that is celiac disease. They've improved on the diet, and we might need to repeat a biopsy further down the line. So if someone has what we call IgA deficiency, which is what I was talking about here, then really we know that an IgA TTG is not an accurate test, and we need to move and do different tests, which test for another immunoglobulin, which is IgG. That's where we'll do an IgG TTG or DGP. So these are measuring other antibodies that get raised in people with celiac disease. And then obviously we do a biopsy. So I hope that's not confused people, but really it's not as straightforward as sometimes one might think, and that's why we need to go back and forth and raise our concerns if there's clinical suspicion of celiac disease. So some key things to consider are definitely that patient needs to be on a gluten-containing diet for 6 weeks. We need to always remember IgA deficiency, total IgA, as well as an IgA TTG is needed. A biopsy without celiac disease blood test is not enough for a confident diagnosis, because villus atrophy can be caused by other things that aren't celiac disease. So that's why we also need that antibody to confirm. But we can see people who have seronegative celiac disease. It's only about 3 to 5%. And for these, again, we'll do biopsies, see if they improve on the diet. We might want to do genetic testing. So we might do a few things. The genetics, just to remember, they're useful when we're trying to exclude celiac disease, but they definitely cannot confirm celiac disease, because people without celiac disease can have positive genetics too. We need to understand that in medicine, every diagnostic tool has limitations. So biopsy also has limitations. I think a lot of people say it's 100% gold standard. Well, we need to understand that location is important. So sometimes, ideally, it should be taken samples from the duodenum, but some people have damage in the jejunum further down. Also, it's about the number of samples. So sometimes we see a biopsy that has 2 samples. Well, that's not enough. That's not representative of what's going on in the gut. So really, we need 4 samples or more. And the orientation is important, where an experienced pathologist will orientate it in a different way to someone who might be inexperienced. So the orientation of that biopsy is important, because there's a subjective assessment to see if there's actually villus atrophy or there's damage there. And really, we need to understand that there's no one perfect diagnostic test that will work 100% of the time in medicine. So we need to bear this in mind with celiac disease too. So what are the complications of celiac disease if we have this ongoing damage in the gut caused by gluten and it's not removed? So we do have research to suggest that there can be higher mortality because of some of these complications I will talk about. We know that about 30% of patients with celiac disease develop hypersplenism. We don't have a tool to identify these patients, but they've got essentially reduced spleen function, which is why Celiac UK recommends that they have a pneumococcal vaccine for pneumonia 5 yearly, a yearly flu jab, and a meningococcal vaccine for a certain age group too. So really, we need to understand that it can affect the immune system too. There's also a small but increased risk of developing intestinal lymphoma or small bowel cancer, which again is more frequently seen in older generation and usually early on in the diagnosis, which is why really what we want to do is make sure the patients are following the diet properly from diagnosis. There's a risk of ulcerative jejunal ileitis. That's always a hard one to pronounce, where there can be ulcers in the small intestine. This is more associated with refractory celiac disease when there's that ongoing damage there too. As I've mentioned, there's problems with fertility too that are associated with celiac disease, and that's why it's really important to get patients on the diet, because antibodies can interfere with fertility. There's also deficiency of vitamins and minerals. There's a few different reasons why someone might have issues with that. We see that people can have low bone mineral density because they can absorb calcium and vitamin D in the right way, and obviously that patients can have ongoing symptoms too, which is going to be a burden for the healthcare system, and they will need resolving. And really, because people with celiac disease have an autoimmune condition, there's a risk of developing other autoimmune conditions, kind of dependent or independent to the gluten-free diet. So what are tools for monitoring celiac disease once we have someone diagnosed, for example? So this is a diagram I really enjoy sharing because it gives you a kind of hierarchy of things that we can do. So this antibody test, that TTG, yes, it's really useful at diagnosis, but what we know is that it's not that useful many times on follow-up. We know that for patients where this TTG is negative, there's a really good systematic review from 2017 that actually showed that when compared to biopsy, it was almost like flipping a coin, because when we had a negative test, 50% of the times it would tell you that, yes, there's no damage in the gut, but 50% of the times you'd have a negative TTG, but there's still ongoing damage in the gut. So really, it's not that predictive of what we call villus atrophy or ongoing damage, right? So we cannot use this test alone. What we know is that if we use a combination of questionnaires, and these validated adherence questionnaires, which are developed to be used in any sort of environment and quickly, they essentially ask the patient about certain symptoms and how they're following the diet, but really they've got significant limitations, because what they ask is things like, you know, are you checking food labels? Do you eat gluten voluntarily? So it's asking about voluntary ingestion, and you know, if someone's checking food labels, that doesn't really tell you if they're checking them right. And this is why it's really important to understand that a lot of the research suggests that the gold standard non-invasive tool is definitely having an expert dietitian or specialist celiac disease dietitian who can really unpick all of these things, where we can go through labels, see if they're checking cross-contamination, see if they're doing things in the right way. And that's going to give more value than some of these questionnaires, because we know that patients over-report their adherence. Many patients eat gluten without knowing they're doing it, because they might not have the level of education needed to follow the diet properly. So there's a kind of relatively new kid on the block too, which some of you might have heard of, which are GIPs, or gluten immunogenic peptides. The idea behind these is that essentially in gluten we have these peptides that don't get absorbed in the body, and they pass through stool and urine, and this is what these GIPs are getting tested for. So essentially they have the potential to tell us if somebody is eating gluten within 2 to 7 days, depending if it's a urine sample or stool sample. These tests are commercially available. They're not really used, they're not used that much in many centers, at least in the UK and in a few other countries. But really, you know, we need more testing to see what role they need to play. They seem to have a lot of promising data, but unfortunately, even if we do that with a patient and we don't educate them, it doesn't tell us where that source has come. It just says you've eaten some gluten in the last few days. So really, we always need that structured education. And also we have the endoscopy. Again, we can repeat endoscopy and a biopsy too. And if there is damage there in the gut, we know, right, there's definitely damage there. But the challenge here is that, you know, this is going to be an invasive procedure. Many patients don't want it. It's costly too, and you're not going to be performing a biopsy every time you see the patient. So really, what a lot of centers will do is they will have a sort of criteria as to when they would do this. So really, in celiac disease, the important thing here is that it's not about picking one tool over another. It's about understanding when to use each tool. And I think as dietitians, we're the gatekeepers here to understand what tool might be useful when, because if we know patients following the diet strictly and they've still got symptoms, then we know, right, do we need to perform a repeat biopsy? And really, we can pick up things in terms of adherence that maybe these questionnaires or a TTG won't pick up. So it's really important to understand and get the balance right with what we need to do. And our assessment is definitely the gold standard from a non-invasive point of view as things stand. So what happens then when we assess these patients and they come back with symptoms? So we know that around 30% of people with celiac disease will come back with symptoms at some point. And this is some really good, this is a really good diagram from a research paper, which actually talks about the different causes of some of these symptoms in what we call non-responsive celiac disease, where we think the patient isn't responding. And we know from research that gluten exposure is the most common cause of ongoing symptoms, and it accounts for about 30 to 50% of ongoing symptoms, which is why it's really important when we have a patient with ongoing symptoms that they get assessed by a dietitian, so we know, right, are they doing the diet right? And then we can correct that and avoid any unnecessary tests potentially. Now, we also know that people can suffer from pancreatic insufficiency too, where we might want to do certain tests, which I'll talk about shortly. They might have small intestinal bacterial overgrowth, so we've got to keep an open mind. Sometimes it might be active celiac disease, sometimes it might not. It might be something else coexisting with celiac disease. We know it's common to see things like lactose or fructose intolerance, so we need to bear that in mind. Other things like microscopic colitis can be common too. We know that quite a few patients can present with functional disorders, which can be IBS or IBS type symptoms too, and they might need an adapted diet. And we know that some people can present with refractory celiac disease, which is a type of celiac disease that doesn't respond to the diet and needs medical intervention. So really, it could be any of these. So we need to understand what process to follow to diagnose these things. So this is, again, from another really good research paper summarizing a diagram of what to do from Sheffield, which are one of the main refractory celiac disease centers in the UK. So they're fantastic at this. And essentially, it's really important that when we see these patients with ongoing symptoms, the first thing we do before jumping into anything is reviewing the diagnosis. I've come across quite a few patients where we review the diagnosis and actually, you know, the diagnosis wasn't done right. It might have just been done with a biopsy. They've not had blood tests too. And actually, when we confirm things, it's not celiac disease, so it's something else that's causing the symptoms. But once we've confirmed the diagnosis, really, and what we want to wait is for something between 6 and 12 months to see if there's been improvement on the gluten-free diet, we might want to consider other things. And this is where things like colonoscopy, fecal elastase, fecal chiroprotectin, so we're checking for other conditions can be useful. We'll check some bloods too. And we want to try identify, is it microscopic colitis, pancreatic insufficiency, these sorts of things. But if that essentially comes back normal, and we see that actually when we perform a repeat biopsy, there's no villus damage, there's no damage there, then we can actually say, right, this potentially could be functional symptoms. It could be more of a food intolerance or bacterial overgrowth, right? But if essentially we do that repeat biopsy and we see there's ongoing damage in the gut, there's ongoing active celiac disease, then that's where we definitely want to make sure there's a dietitian review to make sure it's not that the patient's not following the diet without knowing it. We have a cohort of patients who can need what we call a super sensitive diet, which is an adaptation of the gluten-free diet. I'll talk about that in the next slide, but we might need a bit more of a restrictive approach due to cross-reactivity or cross-contamination. And some people will have what we call slow healing, which is why for a lot of people, we don't recommend a repeat biopsy after a year, because the gut can take time to heal, more than a year. Sometimes, you know, we know it can take up to 2 to 5 years for some people. So really, with a repeat biopsy after a year, it might not be that they're not following the diet, it might be that they're just healing and recovering. And really, you know, when we repeat that biopsy and we've got concerns about the patient, we always obviously need to consider, is it refractory celiac disease? And there's 2 types of refractory celiac disease. Unfortunately, refractory celiac disease type 2 has got a 50% survival rate within 5 years. So with these patients, we really need to treat aggressively. They can have really bad malabsorption and need parenteral nutrition too. So we've always got to be aware that these patients where we've seen really clinical, you know, really bad symptoms, signs and symptoms and malabsorption, that we need to treat that quickly and refer to a tertiary center, so specialist center like Sheffield or Cambridge, for example, so they can deal with these patients. So what sort of follow-up is recommended then? So this is not from the UK. This is from our celiac disease European guidelines. I've used that because I think it's quite a good overview. So essentially, at diagnosis, definitely really important to have a dietitian involved. Some centers will have a gastroenterologist too. Actually, probably most of them, it's actually dietitians that aren't that well funded in most centers, but essentially really important that we educate that patient how to avoid gluten, what celiac disease is, so they understand the complications and why they need to really, or why it's so important to follow this diet. It's good to talk about family screening too, membership of Celiac UK, absolutely key. It's important to consider blood tests so we can have a baseline of absorption of some of these vitamins and minerals too. And then really we want to review that patient at something like 3 to 6 months, but ideally something like 3 months, so we can assess symptoms. Are they coping? How are they finding the diet? A lot of patients find it quite challenging. I'll talk about that next session too. And really want to assess those symptoms, make sure they're improving, potentially check the antibody test. But again, we need to take that with a pinch of salt, really, because it's not going to tell us exactly what's going on with the diet in terms of adherence or with gut damage. And really at 12 months, we definitely want to repeat some blood tests to see if they've normalized, if there is vitamin and mineral deficiencies too. We want to check the diets to make sure everything's going well. And then what we want to do is we want to continue reviewing that patient annually. And that's what our British Society of Gastroenterology suggests, that these patients get an annual review, annual blood test, And then I will also talk about things like bone scans too in another slide. So some of you might be wondering, so what bloods are required? So the British Society of Gastroenterology in their guidelines from 2014 suggest that for gut absorption, we should be checking these bloods, so things like a full blood count, hematinics. We want to check that these are absorbed in the duodenum, really. We want to check things like calcium, vitamin D too, and we want to check for other associated autoimmune conditions that can really onset at any point. So we mainly want to be checking for thyroid function, blood glucose, HbA1c for type 1 diabetes, and then for liver disease, because we know there's a higher chance of having raised liver enzymes in celiac disease. And we want to do that antibody test, but again, we need to take that with a pinch of salt, because not even a negative TTG is not always going to tell you that there's no gluten or no damage in the gut. So some of you might be asking about things like bone scans. So this is a bit of a tricky area because we have different guidance suggesting different things. Some people might use something like a FRAX score, for example. There's other scores out there that help assess the risk of that patient potentially having a bone fracture, having weaker bones. So what we want to do really is identify who we need to screen and who we don't. The BSG guidelines from 2014 suggest that we should measure it after a year on the gluten-free diet for those that have higher risk factors over the age of 55. But again, that's grade D evidence. We don't have a lot of evidence there. We know that the BSG also created some guidelines specific to osteoporosis for people with celiac disease, and they actually suggest that we should do it with those that have persisting symptoms of the gluten-free diet and potentially have something else like weight loss or a low BMI, higher age, because we know this can increase the chance of having weaker bones. But we also need to bear in mind that there's some modifiable and non-modifiable risk factors where this can increase the risk of having weaker bones. So using steroids, things like smoking, alcohol excess, again, things like low body weight too, low calcium intake. So I think people with celiac disease, when we look at this, there's a lot of them that will have some of these increased risk factors, and this is why certain places, certain hospitals will do something like a baseline bone scan after a year for everyone, so at least you know what it is at baseline, and you know if you need to repeat it. But I think it's always worth having a discussion with a health professional if you're not sure about it, if you think that that patient could benefit from a bone scan. But there's some kind of guidance here which might help too. So I guess in conclusion, really, we've got these digestive and non-digestive symptoms of celiac disease. So patients are going to present in many different ways, which is why I think it makes sense to have a low threshold for screening, as a lot of this guidance has suggested, because there's many circumstances where it'll be beneficial to screen someone with celiac disease. The sooner we get them diagnosed, the sooner we treat them with the right treatment. The non-biopsy approach, I think, can be quite a big positive for patients. And really, this helps because they don't need to eat gluten twice. They just need to eat it for the blood test too, gets them screened quicker, less invasive too. So I think it's a positive, but this is just interim guidance at the moment. So I don't know if that will continue long term. I think there's a good chance because there's a lot of data being collected about it, and I think it's working pretty well, but we will see. The diagnosis is definitely not always straightforward with celiac disease, and that's why it's really important that we've got clinical suspicion. We continue to raise that because, you know, some people might not have raised antibodies for the biopsy is not always done in the right way. So we always need to bear that in mind. And patients with ongoing symptoms definitely need individualized support and advice. This is absolutely key in non-responsive celiac disease, and I think discussions with gastroenterologists working, you know, between dietitian gastroenterologists can be really important there. And regular follow-ups with a dietitian, I think, are really important, so we can establish people on the diet, make sure things are going right, and have that follow-up in case there's ongoing symptoms too. Now, this is ideal, the guidance suggests it, but I definitely don't think it's realistic in the way that we don't have funding to have dietitians, especially those specialized in celiac disease, in many of these services across the country. So it's a big challenge at the moment to get these patients with celiac disease the follow-up that they need. There's a handful of references there if anyone wants to read them, but hopefully they can help if anyone finds any use for them. And I just want to say again, huge thanks for listening to everyone. I've really enjoyed that, and I'm really looking forward to your questions. Really active on social media. If I can't answer all of them here, definitely you can let me know through social media too. Thank you.
Kristen, thank you so much. That was amazing. I've got two major feelings around this. Is one, I'm so excited because I've learned so much. You know, I can't believe how much I'm learning. And also so is everybody else, because there's phenomenal amount of comments saying thank you so much, this is fantastic, and a huge amount of questions, so everybody else is as well. But I also feel partly a dinosaur because everything has changed so much since I was in NHS clinical practice. So unbelievable changes, and I absolutely have to listen to this all over again just to really digest it all, but thank you so much. Now, because we've got a huge amount of questions, I really want to rattle through them with you and make the most of your time here,
Sure.
but we just have to rerun the poll question really quickly just to see how everybody's feeling. So Pip, if we could just run that again, if everybody could just vote on that, that would be absolutely lovely. So the statement again is, I'm very aware of who needs to get tested for celiac disease and what specific tests are needed to confirm a diagnosis. So yeah, how do you feel now after that? Thank you so much for voting. So I can just comment on before, really, either people felt they strongly disagree, or it depends. There was about 66% feeling in that category, and 34% were agreeing or strongly agreeing in that category before. So let's see how we're feeling now. So Pip, if we could show those results, thank you very much. Great. Just gonna get those up on the screen. So you can see, like, obviously a massive swing there. You know, with the majority actually now moving to the agree and strongly disagree category. So Christian, not surprising, well done. And
Good, thank you.
Really lovely to see that. So let's get on to the questions really quickly. Now there was one thing that we were chatting about beforehand, and I just wanted to cover that because somebody else has also asked about that. So it's really just to expand on any more challenges that you see with diagnosis and why a duodenal biopsy is not enough for diagnosis. If you could just expand on that for us, that would be great.
Yeah, sure. Good. I'm really glad someone's asked about that, because there's a slide I couldn't fit in due to time, but I've got it here. Let's see. Let me just see. Oh, here we go.
Yeah,
so I hope everyone
we'd hit that first because I knew you'd taken it out.
Yeah, definitely. So I hope everyone can see that there. So essentially what happens is, so this is a really good diagram for Interreg UK. So we were to zoom in on what we're looking at when there's when we take a biopsy, right? We're looking at there's a Marsh score there, and really what we know is that Marsh 0 means that's healthy gut mucosa there. Then Marsh 1 is where we start to see these raised intraepithelial lymphocytes I talked about in the diagnostic slide. So we start to see some features of immune activation there. And in a biopsy, we see something like a Marsh 1. That is definitely not enough to diagnose celiac disease. And we know this can be caused by different things like non-steroidals, bacterial overgrowth. We know it can happen in IBD, a few other things. And that's never enough to diagnose celiac disease anyway. What can happen though is that there's more features of gut damage, which are these elongated crypts, or what we call crypt hyperplasia, where you can see they're a bit elongated there in between each other. And really this is where it starts to become enough to diagnose someone with celiac disease, and it's what we call Marsh 2, when they have raised intraepithelial lymphocytes and they've got this crypt hyperplasia. You can actually diagnose someone with a Marsh 2 without having villus atrophy, right? As long as they've got a TTG that's elevated and a Marsh 2. But then there's more damage that occurs, and this is where we see from Marsh 3A to 3C, which is different types of damage to the villi, where we see things like a bit of villus blunting to total villus atrophy, where they get really flattened there. And that's where we can see that damage. But again, if we were to say we don't do a blood test and we just go in and we see this villus atrophy, here in this diagram from another research paper, you can see that villus atrophy is caused by all these other conditions. So celiac disease is only one of them, but you can see things like H. pylori can cause villus atrophy. Things like B12 deficiencies or other vitamin and mineral deficiencies can cause it. Non-steroidals, again, things like small intestinal bacterial overgrowth. So this is why it's really important to not just take a biopsy on its own, because that damage not necessarily will come from celiac disease. And we know that about a third of patients with negative celiac disease serology actually have celiac disease. So it's really important to consider this with testing. We shouldn't just be taking a biopsy. We need that blood test too.
Brilliant.
Does that make sense?
Yeah, absolutely. I mean, it's so, you're really acting at such a high consultant specialized level here, you know, and it's just so evident about how much clinical expertise is really needed with this. You know, so yeah, thank you for sharing that, and we'll be able to share a copy of that with the other slides for everybody to sort of reflect on that.
Yeah, sure. I think it just really helps to understand this, so we can, I think we're not doctors, but it's good when we understand this so we can help to guide patients.
And yeah, absolutely. Now, question here, this is from Lucy Jones, is there a reason why the prevalence is increasing? Are we just more aware of it, or are we becoming more prone to it? Do you want to comment on that? A few people have actually asked that.
Yeah, really good question. So I think we're definitely getting better at testing it, but I think we need to also be aware that there's a really high percentage of patients that are undiagnosed. But I think also it's not just down to exposure of gluten, because we've got research that suggests that there's no association. There's actually some interesting research suggesting that in countries where there's been a rapid increase in wheat consumption, then there has been an increase in celiac disease prevalence. But it's down to a lot of these environmental factors that are causing it to. And I think we need to put our hands up and also say that we don't fully understand how much of it is genetic versus environmental, what is driving it, but we're definitely seeing an increased rate in prevalence. So this is where, with this prevalence data, we can see associations, we can track it, but causality is really difficult to draw. There's so many different potential causes for it, and that are interacting in different ways.
That's so interesting. Someone else was also just asking a question related to that. You mentioned infant feeding practices as a potential cause. Can you expand on what that is?
Yeah, so it's also thought that things like breastfeeding could potentially be protective too. But really, the whole idea is that potentially introducing gluten too early into the diet can cause this raised immune response, which could potentially trigger celiac disease. But again, it's another area, which is why when I talk about the causes, it's really hard when you look at data. They're kind of looking at it backwards, and it's really hard to say that specifically doing that is going to cause celiac disease, because it's like, is it going to cause celiac disease in more people who are a bit more genetically predisposed, who might have some of these positive genetic tests potentially? So it's really hard to draw conclusions, but what the research does suggest, it kind of points towards some of these things potentially being involved.
Brilliant. Okay, thank you. Really interesting presentation, getting lots of Frank Arsenideas. I'm sorry if I don't pronounce that correctly. I'm really terrible with pronunciations. He said, really interesting presentation, thank you. I didn't quite catch celiac disease and type 1, type 2 diabetes comorbidity. Did you say 5% of those with type 1 diabetes go on to develop CD?
Yeah, so
that could mean we should be more aware of this in our diabetes clinics, for example.
Yeah, definitely. So basically, it's mainly with type 1 diabetes, because type 1 diabetes is an autoimmune condition that is associated with celiac disease. So we know that, and this is why the NICE guidance suggests that people diagnosed with type 1 diabetes or autoimmune thyroid disease within the first year of having that diagnosis, they should be screened for celiac disease. Now, I do see some doctors that actually will almost screen periodically for celiac disease in these patients. In the same way that with celiac disease, we would screen for type 1 diabetes and autoimmune thyroid disease periodically too. So I think the guidance isn't that clear in terms of saying you should be doing it with these patients yearly. It could be good practice, but I also think that if you're a dietitian seeing people with type 1 diabetes, it's really good to have that in the back of your mind and think, actually, this could be triggered at any point if they present with digestive symptoms or some of these non-digestive symptoms. Is it worth speaking to a doctor and saying, shall we screen for celiac disease? Even something like fatigue, unexplained fatigue, which can happen where they don't have any other symptoms, you could say, actually, should we screen, because this is a higher risk individual.
Okay, thank you for that. Annette Anderson, do you also do genetic testing to look at celiac disease risk?
In my practice, so what we do with the genetic tests, we don't really do them in routine screening, because we just do the TTG blood test and endoscopy, or the TTG and EMA. As I said, we're doing the non-biopsy approach. Our guidance suggests that that's enough. You don't really need to do the genetic test. We usually would do genetic tests when there's something that isn't too clear and that can contribute to the diagnosis. So this is where, for example, if someone presents with what we think is seronegative celiac disease, where the TTG doesn't raise, and we want to investigate further, we do a biopsy and we see damage, we see they improve on the diet, then we might want to do genetic tests and say, right, they've also got positive genetics. This really helps to certify that diagnosis. So that's mainly where we'd use it, or potentially the other way around, where if they have negative genetics, we can say, right, this person very likely doesn't have celiac disease, so we don't need to worry about further testing. And that's where it might be useful if we're thinking, is it non-celiac gluten sensitivity? Well, if we've got a negative genetic blood test, we can say, right, this isn't celiac disease, so it's more likely something like non-celiac gluten sensitivity. But that's a whole other talk.
Awesome. Thank you. This is from Avni Vyas. Is there a relationship between prevalence and infants who are given wheat products earlier or later? I mean, I did read something that actually if you introduce wheat products between 4 and 7 months, that actually there might be a reduced incidence. So that, I don't know if that's correct, but related to that question.
Yeah. So I mainly work with adults. So to be honest, I'm not completely up to date with all of that guidance there. I think I did see some research that was published, I think it was last year. And that's where, again, it comes back to what I was saying about the causes, where we know there's some data about it. It's not very clear, and it sometimes can contradict itself. So I don't know the most recent guidance with regards to that, because I don't really work in pediatrics, unfortunately. But it may well be that there's some guidance that kind of contradicts that.
Yeah. Sorry, Christian, you are in adults. I shouldn't have asked you that, really. Sorry.
No, that's fine. It's good. It's good to try and answer these questions, because there are some things I know about pediatrics, but yeah, that one in good detail to answer, I don't.
Absolutely, thank you. So, question here from Ekaterina Godania. If you don't have classic symptoms, how likely is your GP to refer you for celiac disease? And I suppose, or for a celiac test, and given that 75%, I suppose that you said is undiagnosed, how can we improve this situation?
Yeah, so this is why I'm a huge fan of Celiac UK. So Celiac UK do so much work to